Typically, we see these in the $3,500 to $7,000 range. That's pretty good when you're talking about medical expenses. That puts a cap on it. If you're having a really bad year, that's as bad as it's going to get. And that ought to be one of the things that you look at whenever you're shopping for Advantage plans. You're looking at your Advantage plans. You want to know, what is that maximum out of pocket? If I'm having a bad year, how bad could it get? PPOs give you more flexibility. Now, they have a network also. If you stay within their network, you get the best deals, but you do have the flexibility, the freedom to go outside of the network and go to a physician of your choice. But there's a trade-off there. There's a financial trade-off that you're making there. One is that they're going to have a higher maximum out of pocket. Typically, we see these in the $7,000 to $12,000 a year range. Murphy's Law says if something happens, it's going to happen to you in November. And then lo and behold, the end of the year rolls around and you got to do it all over again in January and February. So that would be my luck. If you go outside of the network, this is going to get really expensive because typically you're paying 40 to 50% co-insurance on services outside of the network when you have a PPO. Advantage plans are guaranteed issue. That means no matter what your health condition is, we can get you an Advantage plan. They're not going to deny you. But there's a couple of things. You're going to pay deductibles, co-payments, and co-insurance. And the illustration that I use is, although the premium was zero, they're going to get their money from you on the back end. So let's say I have an earache and I have an Advantage plan. And my wife says, you need to go get your ear checked. Okay, so I go to my primary care physician. Doctor checks me out and says, I don't see anything. Didn't cost me anything to see my primary care physician, or maybe cost me $20. It was cheap. I'm gonna send you over to this specialist over here. Let him take a look at it. And you know what? I want to send you to this specialist over here too. Oh, well, they each have copays, and they're specialists, so they're higher. So I'm paying $30 to $35 for each of these specialists. This specialist looks at it and says, I don't see anything, but sometimes an earache could be a sign of a tumor. I'd like to get some imaging, so I'm gonna order an MRI. Oh, guess what? I got a copay with that procedure. And this doctor over here looks at it and says, I don't see anything either, but could be an infection. Bacterial infections are pretty easy for us to find. Viral infections are harder to detect. I'm going to order some blood work. There's a copay for that too. Every time the carousel goes around, somebody's collecting a copayment from me, and all of a sudden my little earache is getting expensive. And that's how that works. They're going to get their money from you when you use it, as you use it. Here, you're paying in advance. Here, you're paying as you go. Also, over here, your health care is between you and your doctor. Here, it's between you and your doctor and your insurance company. They have this thing called prior authorization. And that means your doctor wants to administer a procedure of some sort. You have to contact the insurance company and say, hey, do you guys authorize us to pursue this route? And that's a very controversial topic, the prior authorizations. And it's probably the most frustrating aspect of all of this. I think if most providers had their way, a provider being a doctor or hospital or something, they would like to see their patients over here because they're human. And they want to take care of their patients the way that they think is best. Over here, they have to go through the insurance company. It's an administrative headache to do that. And it's frustrating because sometimes the insurance company doesn't cooperate because they have to make the case that it's medically necessary to do so. This whole matter of prior authorizations is a deal breaker for me personally. The Medigap is subject to medical underwriting. Now, there's an exception to that. The exception is that means that they can ask you questions about your health, and they can actually deny you. So it's a not guaranteed issue. It's subject to medical underwriting, except for the first 6 months that you get on to Part B. The first 6 months, you have an open enrollment period for Medigap, and you can get on to any Medigap plan that you want to. No questions asked. Doesn't matter if you have heart problems. It doesn't matter if you have diabetes. Doesn't matter if you have cancer. I'm going to focus. There's a whole variety of Medigap plans here. I put an M here because it's Medigap, but there's not a plan M. But they all come with letters, as though this A, B, C, and D and all this stuff isn't confusing enough. Medigap plans have letters also. We're going to focus on a Plan G today for the point of discussion. Some of the plans have been discontinued, and they're not really relevant. There's some others that are active, but they're not very popular. The reason that the Plan G is popular is because it is the most comprehensive of Medicare plans, of the Medigap plans. With a standard Plan G, you pay a $240 deductible the first time that you go to the doctor during the year. And after that, you can go as much as is medically necessary. There's a high deductible version of a G also. And instead of $240, you're going to have, this is really a maximum out of pocket. You're going to have a $2,800 maximum out of pocket for the year. And that brings the premiums down really low. I don't think that's a good long-term strategy because remember we said these numbers go up over time. $2,800 may not sound like too big of a deal when you're 66 years old. But when you're 76 years old and some time has gone by and inflation has factored into that, that might be, we don't know, it might be, $6,000 or $7,000 a year down the road. And that's going to kind of be a drag when you have to hit a high deductible every year before your insurance kicks in. So I don't think that that's a really good long-term strategy. Let's talk about premiums so that this will make more sense to you. I use the example of a male age 65 in Texas non-tobacco user. And those premiums tend to be around $150 a month just for the Part G premium. Could be more, could be less, and depends upon the plan. But they go up over time, and it might look something like this. At 66, 67, 68, 170, 160, 170, 185. Oh, at 69, we're at $200 a month. And it's going to continue to go up over time. That being the case, one of your primary criteria when you're looking at these Medigap plans is not what the brand name is. We don't care what the brand name is because they're all standardized by the government. You don't have to ask your doctor, do you take a plan from this insurance carrier or that insurance carrier like you do over here? You just say, do you take Medicare? If you take Medicare, you're great. And it doesn't matter which carrier that this comes from. Pricing is what you want to focus on. And you want to go with a carrier that has a history of stable rates. And I can tell you, that some of the big names that you're familiar with and you're comfortable with since childhood are not going to be the ones that have a long history of stable rates. They spend a lot of money on marketing and somebody's got to pay for that. So this is one of the advantages of working with a trusted independent Medicare broker because we kind of know these things. And we want to put you with a carrier that will keep your rates stable over time. Now, nobody has a crystal ball to know what the future holds, but there are certain carriers that really pride themselves in stable rates over time. Medical inflation was moving along at a pretty steady rate for a while. And then we hit the COVID lockdowns. Demand dropped off. This is what happened. People who had elective procedures stayed home. And that was really great for the insurance companies because the insurance companies are collecting premiums and nobody's using it. They're like, man, this is good. And then things loosened up, people start moving around again, and all of those procedures that they had put off, that they postponed, they started going back to the doctor and getting that stuff done. Big spike in demand. Well, the insurance companies say, oh, look, we have all this demand now, we're losing money, so we've got to raise our rates. It's almost like when we have hurricanes around here, what follows a hurricane? Increases in your premiums. So it kind of has followed this pattern right here where you have steady increase and drop off and then a spike in rates. And that's taking effect this year. I went to a Medicare conference in Las Vegas earlier this year. Now that was the big conversation here. That and the Inflation Reduction Act that we're going to spend some time on here in just a little bit.